Thank you. Thank you very much for the kind introduction. I'll get going because we have a lot of material to cover today. So this is the plan for today's lecture. Good afternoon, I guess, everybody. My name is Daniele Marin. I'm from Italy, Rome, Italy, and I moved in the States. Maybe a little bit of background about myself. I moved to the States about almost 20 years ago for a research fellowship at Duke. I did my fellowship, research fellowship, clinical fellowship, and I've been a faculty at Duke for probably about 15 years. It's my pleasure to be here today with you guys. I hope this is going to be informative. And again, I will be happy to share my presentation, my PDF, or even the PowerPoint with you guys if you guys are interested. My email is going to be at the end of the lecture. Thank you very much. So the goal for today is basically to review the imaging appearance of benign and malignant focal liver lesions, including primary liver tumors and primary biliary tumors. So let's start with the benign focal liver lesions, because I think it's important to understand, to be able to recognize and to confidently diagnose a benign focal liver lesion in order to differentiate them from more malignant or concerning lesions. The first one I would like to address is liver hemangioma. Liver hemangioma is by far the most common benign focal liver lesion, more common in female patients. Generally, in about 1/4 of the cases, they can be multiple. And the key to understand the imaging findings of hemangiomas is to really understand the pathology, which is like this, like the lesion is composed by a tangle of thin wall endothelial line channels. When lesions become very large, the central portion of the lesion can thrombose and can become fibrotic. The lesion does not have a capsule. It's generally very soft, so it will not cause any mass effect on the liver capsule. And the primary blood supply of hepatic hemangiomas, I just want to remind you guys, is from the hepatic artery. All right. It's important also we'll address the two different subtypes of hepatic hemangiomas, the cavernous and capillary hemangiomas, which have pretty distinct and diverse imaging findings. This is just an example of the typical appearance of hepatic hemangiomas on ultrasound, a echogenic, well-circumscribed lesion in the liver, which in about 60% of cases can have increase through transmission, just like simple hepatic cysts. Just a reminder that the appearance of focal liver lesions is always affected by changes in the background liver parenchyma. This is an example of a hepatic hemangioma in the context of a profoundly steatotic liver. The lesion, generally, we said it's echogenic, but you can see when the liver becomes very echogenic because of the diffuse hepatic steatosis, we can have a reversal of the typical appearance of hemangiomas, as shown in this case, where the hemangioma was relatively hypoechoic compared to the background liver parenchyma. This is the typical appearance of hemangioma on CT. There are three key findings that we look for in order to make a confident diagnosis of hemangiomas. We look for peripheral, discontinuous nodular enhancement that you can see in this example. This is a transverse image of a large hepatic hemangioma. You can see that the enhancement of the lesion is nodular, peripheral, and discontinuous. There is also over time, if we are doing a multiphasic CT acquisition, we will see progressive filling of the lesion over time. And the other very important, probably the most important finding, is that the attenuation, the enhancement, and the attenuation of the lesion of the enhancing component is equal to the attenuation of the blood pool. So always remember to compare the hemangiomas and the enhancement of hemangiomas to the background blood pool. This is another example of a hemangioma. This is a different subtype. This is what we call a capillary hemangioma or flesh-filling hemangioma. You can see that there is, unlike the other example I showed you, we don't really see the peripheral nodular enhancement. The lesion is actually enhancing homogeneously in the arterial phase. and then it becomes kind of iso-attenuating to the blood pool on the portal venous face. Again, the difference between cavernous, which is the most common subtype of hemangioma, and capillary hemangiomas is the fact that capillary hemangiomas have a very fast enhancement, and they become completely homogeneous on the arterial face, as shown in this example. Typical appearance of hemangiomas on MRI, I think it's important to understand and recognize them. What we generally look at is the T2 signal intensity of the lesion is very, very bright, generally not quite as bright as the CSF or static fluid, but it's obviously much brighter than the surrounding liver parenchyma. But more importantly, we look at the dynamic enhancement of the lesion on the MRI, which basically mirrors what we discussed for CT. So peripheral discontinuous nodular enhancement, which is iso-intense to the blood pool on MRI as well. You can see more example of hemangiomas, very bright T2 signal intensity, peripheral, again, discontinuous nodular enhancement and progressive filling on the portal venous face. I really want to emphasize the peripheral discontinuous enhancement because this is a very important finding to differentiate hemangiomas from hepatic metastasis. This is an example of a patient with metastatic breast cancer. And when you look at this lesion, you can see that the lesions have a peripheral enhancement, but the enhancement is not nodular, is not discontinuous. It's what we call a signet ring enhancement or a ring enhancement around the lesion on the arterial face. Again, this type of enhancement is highly suspicious for metastatic liver disease. So very important to look at the appearance on the arterial face to differentiate between hemangiomas. The peripheral nodular enhancement on the arterial face, and the progressive filling during the portal venous phase. I would say that unlike smaller hemangiomas, giant hemangiomas take much longer to fill in with contrast. So many times the central portion of the lesions will not enhance completely just because of the size of these large lesions. Another important finding is that occasionally the central portion of the lesion can also thrombose, and the thrombosis can actually simulate a central scar within a giant hemangioma. This is just a typical appearance of a giant hemangioma. You can see one of the key, very characteristic finding to look for is this area of almost like cystic appearance within the central portion of the lesion, which is highly suggestive or diagnostic for hepatic hemangioma. All right, let's move on from hemangiomas to focal nodular hyperplasia, which is another common benign, totally benign focal liver lesion. The key finding of focal nodular hyperplasia is the fact that the lesion is composed by normal hepatocytes, normal bile ducts, and normal Kupffer cells. In about 60% of the lesions, there will be a central scar, which is, kind of highly suggestive, but not entirely specific. There is no capsule. Very uncommonly, these lesions can contain fat. The primary blood supply, just like hepatic hemangiomas, is from the hepatic artery. And in about 20% of cases, the lesions can be multiple, just like hemangiomas, and there is a strong association between FNH and hemangiomas. This is just a reminder that if you see fat within a focal liver lesion, it's highly unlikely to be a focal nodular hyperplasia. You should be thinking about other focal liver lesions, including HCC and hepatocellular adenoma, if you see fat within the lesion. This is just a typical appearance of focal nodular hyperplasia on pathology. You can see the white component in the central portion of the lesion is the central scar. You can see the peripheral area of hepatic regeneration around the scar. And the diagram nicely illustrates that there is a central feeding artery within the central scar, which is responsible for the hepatic regeneration, basically. On ultrasound, it's very difficult to make a diagnosis of focal nodular hyperplasia. The lesion is, as we said, it's basically composed of normal hepatocytes. So it's almost indistinguishable from the background liver parenchyma. Sometimes when you do like color Doppler or power Doppler, you might be able to see the perfusion in the central portion of the lesion, or the peripheral venous drainage at the periphery of the lesion, but it's not very specific, and it's also not very sensitive. The key for the diagnosis of focal nodular hyperplasia is either CT or MRI with a multi-phasic CT imaging protocol. It's very important to have multiple phases because each phase provides different diagnostic clues to come to a confident diagnosis. The key or most important phase is the arterial phase. The typical appearance of focal nodular hyperplasia, it's to see a sustained and homogeneous enhancement of the lesion on the arterial phase, with the exception of the central scar, as you can see in this example. During the venous phase, what we generally see is fading of the lesion to isodensity. You can see the lesion becomes progressively more difficult to differentiate from the background liver parenchyma. And then the other key finding we look for is the delayed enhancement of the central scar, of the central portion of the lesion during the equilibrium phase. Another example, again, sustained homogeneous enhancement on the arterial phase and fading of the lesion to isodensity, in this case, on the portal venous phase. So in this particular example, you can see the only chance you have to see the lesion is actually the hepatic arterial phase. On MRI, the imaging appearance is virtually identical to CT. The lesion demonstrates, as you can see in the arterial phase, there is a sustained homogeneous enhancement with the exception of the central scar, and then fading to isointensity on the portal venous phase. The other interesting finding on MRI, you can see the central scar has a very characteristic T2 hyperintensity, which is indicative of a very high water content within the central scar. And we will see later on in the lecture, we will see this is a very important finding to differentiate between focal nodular hyperplasia and fibrolamellar HCC. MRI can also provide additional diagnostic information when we use hepatobiliary contrast agents like multi-hands and EOVIST. The typical appearance of FNH on the contrast agents is injected by bolus, and then on the delayed phase, the contrast agent is taken up by normal hepatocytes. And as we said, focal nodular hyperplasia contains totally normal hepatocytes. So it's able to take the contrast media just like the normal liver parenchyma. And you can see that the lesion becomes basically iso to hyperintense on these hepatobiliary phase images. And this is related to the presence of these normal OATP transporters on the surface of the hepatocytes within the focal nodular hyperplasia. We will see this is a very important differentiating finding from, with hepatic adenomas and HCC. Another example of focal nodular hyperplasia with MRI and hepatobiliary contrast agents, you can see the classic finding, the T2 hyperintense central scar, the typical hyper enhancement on the arterial phase, fading to isointensity on the portal venous phase, and then normal uptake of the contrast agent during the hepatobiliary phase. I just want to remind that, the scar, we said it's present in about 60% of lesions, generally larger lesions, but it's not a requirement in order to make a diagnosis of focal nodular hyperplasia. This is an example of a fairly large focal nodular hyperplasia lesion. You can see the typical sustained arterial enhancement, and then fading to isointensity during the portal venous and equilibrium phase. But this lesion, unlike the other example I showed you, showed no central scar that was, to suggest a focal nodular hyperplasia. Again, it's the typical enhancement pattern is more important than the actual presence or absence of a central scar. And I also wanted to show you, just to warn you, is that the central scar is not pathognomonic for focal nodular hyperplasia. This is an example of a patient with HCC. This is a hepatocellular carcinoma. In the setting of cirrhosis, you can see splenomegaly, ascites, the liver nodular contour. There is a hypervascular lesion with a central scar. You can see the lesion is not fading to isointensity, but is showing washout. This was a pathologically proven HCC. And again, that showed a central scar that could be confused for focal nodular hyperplasia. Again, we mentioned the fact that in about 20% of cases, focal nodular hyperplasia and hemangiomas can be associated. This is an example of a patient with both. You can see at the dome of the liver, there is a very T2 hyperintense lesion and a mildly T2 hyperintense lesion within the same section. On the arterial face, you can see and on the portal venous face, you can see the classic enhancement pattern of the hepatic hemangioma with peripheral nodular enhancement, discontinuous enhancement, and the typical enhancement pattern of the FNH with sustained arterial enhancement and fading to isointensity on the portal venous face. Again, the dynamic enhancement pattern, it should basically enable a confident diagnosis. Let's move on from focal nodular hyperplasia to hepatic adenomas. Hepatic adenomas are much less common compared to focal nodular hyperplasias and hemangiomas. The reason why it's important to make a confident diagnosis of hepatic adenomas is because of the potential complications this lesion can undergo. The two most important complications, the most common complication of these lesions is hemorrhage, which happens in about 20 to 30% of lesions. Hemorrhage becomes very problematic when the lesion is large and abuts the liver capsule. And the reason why it's important to understand that is because you can have free rupture of the lesion inside the peritoneal cavity, large hemoperitoneum, and potentially even death related to that. The second important complication, much less common, is malignant transformation of hepatic adenomas. So there is a potential for malignant transformation, and it's important to recognize the signs of malignant transformation with hepatic adenomas. Some of the key findings on pathology of hepatic adenomas, they are also composed of normal hepatocytes like FNH, but unlike FNH, the hepatocytes in hepatic adenomas have a low expression of the OATP transporters, which means that these lesions will not take up the hepatobiliary contrast agent to the same extent of the normal background liver parenchyma. The second important point is the fact that the lesion oftentimes contains fat or hemorrhage, about 50% of cases. Again, they can be multiple, and in some cases, the lesion can be more than 10, and in those cases, we use the term hepatic adenomatosis. I'm not going to go into the details of the genetics, but it's important to understand that we have a much better understanding of the underlying genetic mutations within hepatic adenomas, and different mutations are associated with a different appearance of these lesions. These are the 4 most common subtypes of hepatic adenomas based on the genetic underlying: the HNF1 alpha mutated, the inflammatory or telangiectatic adenomas, the beta-catenin, and the unclassified. I just want to say that the classic finding of the HNF mutated is the presence of fat, and these are the ones that are the most benign. They have a low propensity for bleeding, and they almost never undergo malignant transformation. The second subtype, the inflammatory telangiectatic subtype, it's important to recognize that because of the potential for bleeding. That's the most common complication of the inflammatory subtype. And finally, the beta-catenin are the ones that are much more common to undergo malignant transformation into HCC. I'll show you some examples of that. This is a classic HNF1 alpha mutated adenoma. Again, you can see on the in-phase and opposed phase images, there is a substantial drop of signal intensity of the lesion on the opposed phase images, consistent with intralesional fat. On the post-contrast images, you can see the classic arterial enhancement of hepatic adenomas, and no definitive washout. It's basically the lesion is becoming iso intense, just like FNH on the portal venous phase and equilibrium phase. This is the classic example of a telangiectatic or inflammatory subtype. These are the ones that are more commonly associated with bleeding. What do I look for if I want to make a diagnosis of a telangiectatic? I look at the T2 weighted images. These lesions typically have a very bright T2 signal on the T2 weighted images, and that is very pathognomonic, very characteristic for inflammatory or a telangiectatic subtype of hepatic adenomas. Again, the highest bleeding rate. This is an example of a telangiectatic adenoma which bled. What you see there, this is a non-contrast CT. The high density component within this large lesion is actually consistent with fresh like bleeding within the lesion. There is also some component of intralesional fat. And again, on the portal venous phase, you can see some mild degree of enhancement of this lesion. This is an example of a beta-catenin hepatic adenoma degenerated to a hepatocellular carcinoma. You can see generally the way we diagnose HCC within a hepatic adenoma, we look at two main findings. We look for interval growth, which is generally concerning for malignant transformation, and we also look for washout. You can see this lesion is showing some intralesional washout, which is highly concerning for malignant transformation. Again, growth and washout are the key findings that would suggest a malignant transformation. This is just a nice example showing you the differential between hepatocellular adenoma and FNH. You can see multiple hypervascular lesion. If you only look at the dynamic arterial and portal venous phase, it would be basically impossible to differentiate between those lesions. So what we did, and what you can do in those situations where you're not sure if you're dealing with an FNH or an adenoma, what we generally do, we scan the patient with MRI with hepatobiliary contrast agents. And as I said before, hepatocellular adenomas have a lower expression of the normal transporters for the EOVs, the OATP transporters. And what you can see is that these lesions will become hypo-intense compared to the background liver parenchyma during the delayed hepatobiliary phase. As you may remember that for FNH, we had the opposite pattern. FNH would take up the contrast agent and would become iso-intense compared to the background liver parenchyma. And this is a nice example showing you two lesions. Again, if you only look at the dynamic images, it's impossible to differentiate between FNH and hepatic adenomas. When you look at the hepatobiliary phase, you can see the area of focal nodular hyperplasia has a similar uptake of the contrast agent compared to the background liver parenchyma, as opposed to the hepatic adenoma that demonstrates decreased uptake and lower signal intensity of the lesion compared to the background liver parenchyma. A very clear differentiation between these two lesions using the hepatobiliary contrast agents. Again, when lesions are more than 10, we call this hepatic adenomatosis. Generally, these are very rare conditions associated with glycogen storage disease And, again, we don't see that often. Again, this is an example of a hepatic adenomatosis in a patient with glycogen storage disease type 1, enlarged liver parenchyma, multiple hypervascular lesions that were consistent with hepatic adenomas. All right, let's move on and let's talk about hepatocellular carcinoma, which is by far the most common hepatic malignant liver lesion. 90% of these lesions of hepatocellular carcinoma in Western countries are associated with chronic liver disease. But it's important to recognize that in about 10% of cases, these lesions can also happen in patients without underlying chronic liver conditions. Many times, hepatocellular carcinoma is associated with elevated AFP, alpha-fetoprotein levels in the blood, but imaging provides the most important diagnostic finding to make a diagnosis. Pathology, in a small number of cases, you can see intralesional fat. In about half of the lesions, you can have a peripheral capsule, which is responsible for some of the key imaging findings. Very important, hepatocellular carcinoma has a propensity to invade venous structures inside the liver parenchyma, including the portal vein and the hepatic veins. Not commonly, it can also invade the bile ducts. And the primary blood supply is from the hepatic artery. This is just an example of a classic hepatocellular carcinoma. What we look for is arterial enhancement, increased arterial enhancement relative to the background liver parenchyma during the arterial phase. And then we look for washout and a peripheral capsule during the portal venous phase and the equilibrium phase. And I just want to remind you that if you see these imaging findings, you can make a confident diagnosis of hepatocellular carcinoma without the need of a pathologic confirmation or biopsy. Another important reminder is that in order to diagnose, in order to identify hepatocellular carcinoma, it's very important that we pay a lot of attention to our imaging protocol. And in particular, we pay a lot of attention to the diagnostic quality of the arterial phase. This is an example of a patient, the same patient, that was scanned with CT followed by an MRI. And the reason why the MRI was performed is because the CT was, the timing of the arterial phase on CT was suboptimal. You can see if you only look at the CT image, it's virtually impossible to identify this 2.5 centimeters lesion in segment 5. When you look at the MRI, the arterial phase was actually more properly performed, and you can see a very unequivocal arterial enhancing lesion that was completely missed on the CT just because of the timing of the arterial phase. So again, pay a lot of attention to the timing of the arterial phase when looking for HCC. Classic appearance of HCC on MRI. You can see the arterial enhancement and progressive washout with capsule during the portal venous and equilibrium phases. This is a nice example of what's called a mosaic HCC. When you look at the in-phase and post-phase images, you can clearly notice some drop of signal intensity on the opposed phase consistent with intralesional fat. So in a small percentage of HCC, you can actually identify intralesional fat. And the reason why it's important to look for fat is generally this lesion has a better prognosis. They are generally well-differentiated HCC with a much better prognosis for the patient. Another example, this is showing you a very large HCC, which is basically affecting almost the entire left hepatic lobe. And what I wanted to show you in this example is extension of the tumor into the portal vein, as well as extension of the tumor into the hepatic veins. Again, just to reinforce the fact that HCC has a very high tendency to invade the local vascular structures. Another example, very difficult to actually see the lesion but you can see that this is the posterior branch of the right portal vein. And you can clearly see there is actually a T2 intermediate signal intensity within the posterior branch of the portal vein. On the portal venous face, you can see that there is a clear filling defect within the posterior branch of the right portal vein. And this was actually tumor in vein. And if I ask you to identify the lesion, it becomes very difficult to see it. And the reason is that invasion of the vein generally results in increased arterial perfusion within the liver parenchyma. And this increased arterial perfusion can actually mask or basically obscure detection of the primary lesion. People have used hepatobiliary contrast agent for detection of HCC, and we think there is a lot of value in using EOVIST for detection of HCC. You can see this lesion was hypervascular lesion, somewhat equivocal washout. The liver parenchyma was clearly cirrhotic. When you look at the delayed hepatobiliary phase, HCC, just like hepatic adenomas, they have low expression of normal biliary transporters, and they do not take up the contrast agent relative to the liver parenchyma. So the lesion will appear as a hypointense area within the liver parenchyma. Some people have also used the EOVIST in order to actually grade the differentiation of HCC. These are two separate patients with the same lesion, a hypervascular liver lesion in the setting of cirrhosis, consistent with HCC. And when you look at the delayed hepatobiliary phase, the two lesions, the first lesion demonstrates somewhat preserved level of uptake of the hepatobiliary contrast agent. This was consistent with a well-differentiated, in other words, well-differentiated HCC have somewhat preserved number of biliary transporters, and they can take up the contrast agent to a certain degree. Moderately and poorly differentiated HCC have a lower expression of the normal biliary transporters, and they will show a lower signal intensity compared to the background liver parenchyma on the hepatobiliary phase images. This is just, a very uncommon subtype of hepatocellular carcinoma, what we call the fibrolamellar HCC. Very rare. I would say we see maybe 1 or 2 lesions per year in our practice. But the reason why it's important to understand and to know about this lesion is patients without any history of cirrhosis. And the other important finding is that these lesions typically have a central scar. So you have a large lesion, hypervascular lesion, in a young patient without history of cirrhosis with a central scar. Very often, these lesions get confused for fibrolamellar focal nodular hyperplasia, just because of the clinical context. But these are actually malignant lesions with high risk for metastatic disease. So it's very important that we make a confident diagnosis. So how do you differentiate between a fibrolamellar HCC and a focal nodular hyperplasia? Let me show you some of the findings. So the first thing you look for is calcifications within the central scar. So calcifications within the central scar are virtually pathognomonic for fibrolamellar HCC. The second thing you look for is the appearance of the central scar on the T2 weighted images. If you remember, when we discussed the focal nodular hyperplasia lesions, I showed you multiple examples where the central scar was hyper intense compared to the background liver parenchyma. And I told you that the hyperintensity was related to a high water content within the central scar. This is completely different with fibrolamellar HCC, where the central scar is typically hypointense compared to the background liver parenchyma. And the hypointensity is related to the area of calcifications and very dense fibrosis within the central scar. The second thing we look for is basically lymphadenopathy classically cardiophrenic nodes, and the presence of multiple satellite nodules, which are basically suggestion of intrahepatic metastasis. Again, if you have these findings, you should not be thinking about focal nodular hyperplasia. You should be worried about fibrolamellar HCC. And this is just a table comparing different imaging findings between fibrolamellar HCC and focal nodular hyperplasia. This will be in your material or from the lecture. All right, so we discussed pretty much all benign and malignant focal liver lesions that contain hepatocytes. Let's switch gears and let's talk for the last like 10, 15 minutes about biliary malignant lesions. The first one I want to discuss is biliary cystadenomas. Biliary cystadenomas are benign lesions. They do have a malignant potential, so it's important to make a confident diagnosis of these lesions. And they typically appear in middle-aged, late-age women. The classic appearance on pathology of biliary cystadenomas is the presence of a ovarian-type epithelium along the wall of the lesion. It really reminds on pathology, it really resembles a mucinous ovarian neoplasm. They can be unilocular or multilocular, so they can have septations. And the reason and the way you differentiate between a biliary cystadenoma and a simple cyst is by looking at the wall of the lesion. The wall of the lesions are generally thickened, much thicker compared to a normal hepatic cyst. And the same applies for the intralesional septations. As I said, they do have malignant potential. This is an example of a malignant biliary cystoadenocarcinoma. You can see that what we look for is basically very thickened septa and walls of the lesions. Interval growth, if you have serial imaging, you can see the lesion will grow pretty substantially over time. And then you look also for these kind of areas of nodular enhancement, either within the lesion or within the wall of the lesion. So anytime you see nodules, enhancing nodules within a lesion, within what looks like a biliary cystadenoma, you should be worried about potential malignant transformation of the lesion. So degree of thickening of the septa and the wall and presence of nodules and interval growth are the most important finding to differentiate between biliary cystadenomas and cystoadenocarcinomas. The other biliary neoplasm I wanted to discuss is cholangiocarcinoma. The reason why I want to discuss cholangiocarcinoma is because this is today in the Western countries has become the second most common malignant primary liver tumor. Has a higher propensity for male, generally middle or older gentlemen, and is typically the pathology of these lesions is generally a adenocarcinoma, but the key finding on pathology is the presence of a very rich fibrous stroma within the lesion. And the reason why I'm pointing out and I'm emphasizing the fibrous stroma is because this finding will be responsible for one of the key imaging findings of cholangiocarcinoma on CT and MRI. There are important risk factors for cholangiocarcinoma. Primary in Western countries, generally, primary sclerosing cholangitis is by far the most important risk factor, choledochal cysts, and infections as well. There is also a subset of cholangiocarcinomas that can happen more commonly in patients with cirrhosis. So that's important to understand. The classification of cholangiocarcinoma can be based on two different aspects of these lesions. One is the anatomical location of the lesion. There are three different subtypes of cholangiocarcinoma based on the anatomical location. What we call the intrahepatic or ICC cholangiocarcinoma, which happens which arises from the peripheral intrahepatic bile ducts. Then you have the central or perihilar cholangiocarcinoma, also known as the Klatskin tumor, which is by far the most common subtype, that affects basically the biliary bifurcation, as indicated in this diagram by the blue like common hepatic ducts. And finally, in about 25% of cases, cholangiocarcinoma can happen outside the liver parenchyma, the liver, and involve the common hepatic duct and the common bile duct. And those are called the extrahepatic cholangiocarcinomas. In addition to the location of the lesion, it's also important to differentiate cholangiocarcinoma based on the growth type. There are three different subtypes. The mass-forming, which is typically associated with the intrahepatic cholangiocarcinoma, which will present, as the name implies, as a focal liver mass. Then we have the periductal infiltrating cholangiocarcinoma, which is most commonly associated with the perihilar or Klatskin subtype. And finally, we have the intraductal cholangiocarcinoma, which is the most common subtype for the extrahepatic cholangiocarcinomas. Feel free to stop me if you guys have any questions. Huh? Okay. Why is it important to differentiate between these three different subtypes? The reason is that the surgery, the type of approach and the surgical intervention are drastically different depending on the location of the lesions. In order to make a confident diagnosis of cholangiocarcinoma, it's very important that we have a dedicated protocol, a multi-phasic CT protocol for the assessment of cholangiocarcinoma. Typically at Duke, we include the hepatic arterial phase, the portal venous phase, just like any other like liver protocol. But the important difference with the other liver protocols is that we always include a very delayed phase, about 10 to 15 minutes after contrast injection. And the reason why we include this very delayed, like post-contrast phase, is that cholangiocarcinoma, as I mentioned before, has a very dense, very rich fibrous stroma, and the fibrous stroma will tend to enhance very late after contrast injection. So in order to demonstrate presence of fibrosis, we need to wait long enough for the contrast to actually get into the fibrotic areas of the tumor. Again, imaging is very important for the diagnosis, for the pre-surgical planning, and for the surveillance of these patients. So these are the common findings that we need to discuss when we look at a patient with cholangiocarcinoma. We need to be able to identify the location, because as we mentioned before, the surgical approach is driven by the location of the tumor. We need to evaluate the extent of involvement of the bile ducts, because again, this has very profound implications for surgery. We need to evaluate the vascular involvement, in particular involvement of the hepatic artery, presence of local regional metastatic lesions and distant metastases. MRI is particularly when we're dealing with like the hilar or perihilar cholangiocarcinoma, the Klatskin subtype. MRI is the modality of choice. This is an example MRI with MRCP, a very nice MRCP image demonstrating not just the bifurcation of the common hepatic duct, but also demonstrating the peripheral, the secondary branches of the biliary branches in a very nice way. Just an example of what we call the periductal or Klatskin cholangiocarcinoma. You can see that, this is the biliary bifurcation. There is this kind of very ill-defined, very infiltrative mass, which is affecting the biliary bifurcation. This is the classic appearance. This is the corresponding MRCP showing you, again, this abrupt cutoff of the bile ducts in the hilar region of the liver. Very challenging sometimes to identify the actual primary lesion on imaging. Another example, you can see the left and right intrahepatic biliary ducts, and then this very abrupt cutoff. You can see this is the confluence between right and left bile ducts, And you can see the distal CBD, but there is almost like a gap in this, in between these two segments. And this was where the lesion was actually located. You can see the corresponding CT. There is a biliary stent in place. You can see this kind of ill-defined tissue. It's very difficult to actually separate normal liver parenchyma from the actual lesion. And this was a very large lesion, actually. And you can see on the importance of the delayed images. If we wait long enough, so this image was acquired probably between 10 and 15 minutes post-contrast injection. You can see there is progressive enhancement of the lesion relative to the liver parenchyma. And we can see this very large mass that was invading the hepatic hilum, which was virtually impossible to identify on the portal venous phase. Again, surgical classification of cholangio. It's very important to actually be able to evaluate the extent of the tumor relative to the biliary bifurcation and bile ducts. And again, the MRI, MRCP images generally provide a very nice demonstration of this extent. You can see that there is in this patient, there was a central hilar lesion with abrupt cutoff of the left and right hepatic ducts. And you can see this area of narrowing, which is basically affecting a very long segment of the bile duct. But you can actually see the extent of involvement of the left and right hepatic duct. And this was actually demonstrated also on subsequent ERCP. You can see that there is a very nice correlation between the MRI images and the MRCP images in this patient. All right, I just want to conclude by discussing the second most common subtype of intrahepatic cholangiocarcinoma, which is the intrahepatic or mass-forming cholangiocarcinoma. This is a cross-section on pathology of this tumor. Again, as the name implies, this lesion presents as large intrahepatic masses. The key finding is the abundant fibrostroma. You can see the lesion in this example was abutting the liver capsule. And because of the fibrostroma, because of the fibrous component, you can see this kind of white, like intralesional component. There is very pronounced capsular retraction. So the capsular retraction, when the lesion abuts the capsule, it's very common, almost always you will notice some capsular retraction related to the intralesional fibrous component. This is another example on MRI. You can see this kind of lesion in segment 5. And you can see on T2 weighted images around T1, you can see there is a very abrupt retraction of the capsule overlying the focal liver lesion. Again, this is indicative of a very highly fibrous component within the lesion. Post-contrast images, they are generally not very specific during the arterial and portal venous phase. You can see the lesion is relatively hypovascular compared to, for example, HCC or other liver lesions. But you can see, again, the very characteristic delayed enhancement of the lesion during the delayed images. These images were acquired about 10-15 minutes post-contrast injection. And you can see that there is delayed enhancement of the fibrous component of the lesion on these images. Differential diagnosis, focal confluent fibrosis, treated metastasis, less common liver lesions like epithelioid hemangioendothelioma. But again, this is an example of a patient with focal confluent fibrosis. Again, we see this very characteristic capsular retraction. So you might think this patient has a cholangiocarcinoma, intrahepatic cholangiocarcinoma, but I would caution you to consider the possibility of focal confluent fibrosis when you are dealing with a patient with cirrhosis. You can see this patient had a very nodular liver contour as well as splenomegaly, and this was a patient with known cirrhosis. And the second thing I would ask you to look at is basically the shape of the lesion. You can see this lesion, when you look at the T2 and T1 weighted images, the lesion has very straight margins. It's not very mass-like. It's more linear in morphology. And this linear morphology in the setting of a cirrhotic patient or a cirrhotic liver is highly suggestive of focal confluent fibrosis, particularly when the lesion happens in the anterior segments of the right hepatic lobe. On the post-contrast images, what people also have described in the setting of focal confluent fibrosis, this crowding of the vessels. When you scan in the arterial phase and portal venous phase, what you typically see in patients with focal confluent fibrosis is that the hepatic vessels are very crowded, are very squished together, which is the opposite of what we see in patients with intrahepatic cholangiocarcinoma, where we said the lesion is relatively hypovascular during the arterial and portal venous phase. All right, guys, thank you very much for your attention. I wanted to leave a couple